Good evening, everybody, and all of you who are joining us. It's a real pleasure that you're joining us for the last Journal Club of the year. And I'm delighted to say that Rossella Ruggiero will present this latest article from JACC Intervention about IVUS in acute myocardial infarction. And it gives me immense pleasure, and I'm so happy. And thank you so much, Prof. Colombo, for joining us. Especially, this is very special for all of us because the Journal Club started with you almost maybe 2 years ago, nearly. I remember sitting in Cotignola and Sala Ovale every Friday morning with you. And so we basically carried on the Journal Club adventure, and here we are, and it's a great pleasure to share this with you. So thank you for joining us, Prof.
Grazie, thank you. It's always a
Ross,
pleasure
you can
to
start.
meet with you.
Yes.
And,
so
I try to do it more frequently.
Absolutely, it would be a pleasure.
Thank you. So, allora, let's start. Let's get it started. Thank you again, Prof. I want also to thank you for your participation and for this great discussion, because you're an expert on this topic, so will be very interesting. So the topic of today is the use of IVUS in a setting of acute coronary syndrome, and in particular, the impact on long-term clinical outcome. So let's start with the background. Why IVUS is important in pre-stenting treatment in pre-stenting. IVUS is one of the most used imaging tool during PCI, because it is able, as you can see, to evaluate the lesion of the stent, the length of the lesion, the diameter, both distal and proximal of the vessel, and also to evaluate the characteristic of the plaque. On the right side of the slides, you can see how IVUS is able to evaluate the presence of calcium, of course, the presence of rupture of the plaque, even if it's a little bit more difficult, and the presence of dissection. But IVUS is also important in post-stent setting. Particularly, it is able to evaluate the presence of malapposition, as you can see, the presence of dissection, and plaque burden outside from the edge of the stents, and also the presence of extensive protrusion in between the stent struts. IVUS has been evaluated in several papers, particularly in chronic coronary syndrome, where its use demonstrates to reduce events compared to angiographic guidance, as you can see, also in long-term evaluation and outcomes. But the most important use of IVUS is in the setting of PCI of the left main. In these slides, you can see a recent published paper on circulation demonstrating the good outcome in patient underwent IVUS-guided PCI for left main compared to angiographic PCI. However, IVUS in setting of coronary syndrome has very few data on the published, and this is the background of this important paper. So patients enrolled in our paper were retrospectively evaluated from 2004 to 2014. All patients included had myocardial infarction, defined according to the third universal definition of myocardial infarction, both STEMI and NSTEMI, who underwent DES implantation. Exclusion criteria were the conservative strategy, balloon angioplasty alone, implanting of bare metal stent, and OCT-guided PCI. The aim of this paper is to evaluate IVUS-guided PCI comparing to IVUS-guided PCI versus angiography-guided PCI in terms of occurrence of MACE, defined as cardiovascular death, myocardial infarction, and target lesion revascularization. Overall, 9,800 patients were included in the analysis. Of those, 2,000 underwent intravascular ultrasound-guided PCI, while 7,800 underwent angiographic-guided PCI. The use of IVUS-guided PCI was left to the operator decision. In these slides, you can see the baseline characteristics of our patient. Overall, the two groups were more or less the same, had the same characteristics, were a young patient. If you can see as in the IVUS-guided PCI, the patient were younger compared to angiographic-guided PCI. Half of the patients were admitted for STEMI. And interesting, in my opinion, is the fact that the IVUS-guided, the enrollment in the IVUS-guided PCI group were much higher in the first 5 years from 2004 to 2005 compared to 2010, from 2010 to 2014. In these slides are reported the baseline procedural characteristics. Half of the, as you can see, the lesion were complex lesion. Patient had, for half of the patient had multivessel disease. The rate of multivessel disease was higher in IVUS-guided group compared to angiography-guided group. The culprit lesion in the half of the cases was LAD. The majority of the patient underwent a second-generation drug-eluting stent, and the rate of bifurcation stenting was higher in the IVUS group compared to the angiography group. In 75% of the patient of the cases in the IVUS group, the IVUS was performed pre and post PCI. As you can see in this part of the slides, the procedural characteristics were were the same in both groups. But the most important part, I think, in my opinion, is the fact that in IVUS-guided PCI, patient underwent more stent implantation with a larger diameter and had a longer total stent length compared to angiography one. And here are the results. At 4-year follow-up, the rate of overall MACE were significantly lower in IVUS-guided PCI compared to angiography-guided PCI. And the same results was observed dividing per se the 3 components of the MACE, so cardiovascular death, MI, and target lesion revascularization. And also the same results were consistent also in the multivariate analysis and the propensity score match score. The author then decided to divide the events from the beginning of the within the first year, as you can see in this part of the graph, and from 1 year to 4 years. And as you can see, the benefit derived from the IVUS-guided PCI was consistent. It was persisted both in between within 1 year and after 1 year to 4 years. Dividing the MACE from each singular component, as you can see, for cardiovascular death, the statistically significance of the benefit of IVUS-guided PCI was much higher, significant within the first year, while after 1 year there were no differences between the two groups. By contrast, for MI and TLR, there were no difference within 1 year between the two groups, while from 1 year to 4 years, the groups started to divide the rate of events. In the slides, you can see the Kaplan-Meier evaluation of the presence of a significant difference from the two groups in both, also dividing the results from each component of the MACE. The authors then performed also a propensity score match analysis, and they find out that the majority of the benefit from the IVUS-guided PCI was observed in patients with chronic kidney disease and in patients who underwent left main PCI. Of course, this paper has several limitations. First of all, it is a retrospective studies. No, image analysis were not included in the main paper, and so this is a very huge limitation. And also, there was the absence of unmeasured confounding factors, such as the decision for an interventionalist to perform or not the IVUS. As we know, usually in acute coronary syndrome, the interventionalist try to reduce the time of the procedure. Therefore, probably this can lead to a selection bias. In fact, patient with less complex lesion had much more likely included into angiography guided groups, while patients with much complex lesion were much likely to have IVUS guided PCI. So in conclusion, according to the authors, IVUS can safely be used in patients with AMI, acute myocardial infarction, without increasing procedural complication. Patients underwent IVUS-guided PCI had larger diameter, and longer length stent. IVUS-guided PCI was associated with a decreased risk for long-term cardiovascular events in patients with acute myocardial infarction undergoing PCI with death, and this beneficial effect persisted after 1 year after index PCI. So, in conclusion, I would like to start the discussion asking to Prof simple question, let's say. First of all, in setting of acute myocardial infarction, which one do you prefer to use, the IVUS or FFR, and how do you decide which one to use in a particular patient? And will you prefer to use IVUS or CT? And which are the benefits of these two type of imaging tools? And at the end also, I don't know, IVUS could be affected somehow by vasoconstriction.
Okay.
And how can we avoid the error in sizing, in setting? So thank you very much.
Okay, thanks, Ross, for the presentation and the summary. Prof, if you would like to comment on some of the questions and also the study and your opinion on this field.
First of all, I am not convinced about these results. To me, there are some unmeasurable confounding factors that affect these retrospective evaluation. I cannot imagine that IVUS has such an impact in lowering mortality. I mean, I know the left main issue. We are aware that in left main, etc., but I mean, in my experience, to do an aggressive pulse dilatation in acute MI, you can have more distal embolization, and I personally will be selective in using IVUS in acute in ST elevation MI. Maybe in a general acute coronary syndrome, maybe, but I will be selective. It depends. So I think there are some unmeasurable factors. I prefer to be more on the old school, to be as relatively quick in acute MI, limit the action, and get the patient in and out of the cath lab relatively short time. Of course, this does not mean that you should not use imaging, but I think if you have a big vessel, you know that is 3.5 or 4, I don't see the need to do imaging. If you have a small LAD, 2.5, and you can go to 3.5, maybe you can use imaging. But to come to the conclusion that imaging in general is better than angiography in acute MI or in acute coronary syndrome, I believe is too strong of a statement that can only be demonstrated by a prospective study, but not by a retrospective study. Regarding FFR, I will skip FFR. I think in acute coronary syndrome, we have so many variables affecting the distal circulation that FFR becomes a little bit polluted by other factors. I will use IVUS. I will not use IVUS routinely. I will use OCT or IVUS. One of the two depends on the experience. But again, I will not use them routinely, even if this study seems to state that they should be used routinely. I believe that this study has some unknown confounders which are not clear from the statistical analysis.
Okay, and what about, Prof, sometimes this issue of vasoconstriction they tell us about? And I've seen some cases where the patient comes back 6 months or 1 year later, aggressive restenosis. You look at the IVUS on the following procedure and you see that the stent was undersized. You go back to the first procedure and you think maybe, so would IVUS have helped avoid the problem of stent undersizing in acute MI?
But you know, if you have a vasoconstriction, the only way to take away vasoconstriction is to have vasodilatation. If you do IVUS, you don't get over vasoconstriction. If the vessel is constricted, even if you do IVUS, you see it constricted. So it's, you know, by IVUS, you don't measure the external elastic, the adventitia. I mean, if the vessel is constricted, it's constricted. If you do IVUS, you still see constricted.
Yeah.
So I don't believe vasoconstriction is overcome by IVUS.
Okay. Okay. So does anybody have any questions regarding this paper or in general from their clinical practice with IVUS? And
let me ask you another question to you people. How many cases in the last 5 years you have seen in acute coronary syndrome using IVUS-guided stenting? How frequent?
I mean, if I go first, I would say less than 1 in 20.
Sì, very few.
Very, very few. Yeah, definitely the minority.
Una conferenza la posso chiamare io fra mezz'ora? Chiamo io fra mezz'ora, grazie, grazie. Grazie.
So I think the general feeling is not so much at all. Very, very few.
Arif, from my side, I can confirm this. Very, very few cases, especially the operators are very concerned, about being quick in the acute setting, and also about the chances of distal embolization if you go in a lesion that has a high thrombus burden.
Yeah, I mean, I would say, I think exactly, some people on the chat are saying that not so much indeed, personally never in STEMI. So I think the majority of people are basically saying very, very little to almost never, Prof. I think you're muted, Prof.
Yes, yes.
Okay. So yes, so we're all saying that very little to almost none.
So yeah, so the general feeling is that IVUS guidance is, in my opinion, I am always afraid to exaggerate in post-dilatation because sometimes post-dilatation and vessel stretching can trigger distal vasoconstriction, and it's not pleasant, it's not easy to correct sometimes. So I would have asked more questions to the authors before accepting this paper.
And on that note, Prof, I know you've obviously done a lot of work with, let's say, large-scale registries and trying to eliminate some of these issues and limitations. With all of us young people who are connected, what sort of advice would you give to us when, thinking about or preparing such form of research or papers in this sort of registry data? Like you said, you would ask more questions. So, for example, what sort of things would you have looked for?
But sometimes if you there are some registries that can be just dealt as a registries, but try to convert a registry into a randomized study, which is something that people do frequently now, is a risky business. Especially if you introduce a variable, such a type of procedure that the operator decides to do. The decision to do is such an important human factor, putting there so many unknown confounders, which I'm a little bit skeptical about these kind of studies, and I prefer not to do the study, because I know that whatever result I find, it will be questionable. So it's there is a strong rationale in one direction, but there is also a strong rationale in the other direction.
Okay.
And there are some why people are so reluctant to do IVUS in acute MI. I mean, it's almost universal feeling. So it's I'm not convinced. If I have an MI, I prefer not to get IVUS on me.
Okay, fine. And just
Arif, I have a question from for Rossella about what Prof said about the methodology of the study. Ross, you have had the opportunity to look in deep in the literature. What about the prospective studies in the literature? How many studies about IVUS in left main we have?
Allora, in general, IVUS in left main on acute coronary syndrome. In
this setting, acute coronary syndrome in left main.
Sorry. Allora, in general, as Prof said, physicians are afraid to perform, not afraid, però it's not a priority to perform IVUS in acute coronary syndrome. In general, the literature are very scarce because there are very, very few papers, all retrospective with few patients. Prospective, I didn't found any, and the retrospective were very, very few. And this is the one with the large number of patients, but of course, as Prof said, has several limitations. There are a lot of unsaid, untold evaluation that they did. So this is the larger one, but prospective I didn't found.
Okay. Prof, one question about SCAD, spontaneous coronary dissection. In this setting, when the patient presents, I know classically a lot of people would teach or would use OCT, but have you found and have you used IVUS in this setting, and have you found it to be helpful? Is there any advice about IVUS in the setting of SCAD?
I think IVUS in the setting of spontaneous coronary dissection makes sense, even if as far as directing decision making is difficult because we know that stenting is not always the best solution, but if you have a dissection with flow limitation, then you need to stent. I don't see any other approach. The question is IVUS or OCT, as you said. Personally, I prefer IVUS versus OCT because I am afraid in a dissected vessel, especially fragile like this patient have, injecting dye further, sometimes at the force pressure to get a good OCT image, may extend the dissection and may become harmful. So I prefer IVUS for this reason, but maybe if you inject very slowly, but you know, it's not so easy. So I prefer IVUS in this setting.
Okay. And just to ask you, has there been any settings where you have used IVUS in acute coronary syndrome, or is it also the same, like all of us are saying, that almost never?
No, I think when you use IVUS in acute coronary syndrome or STEMI, you have to have, before opening the IVUS catheter, you must have a question in your mind, knowing I opened the IVUS catheter to answer this question, which I cannot get the answer by angiography or by clinical. Not just I do IVUS just to take a look.
Okay.
You have to have a specific questions in your mind, like an LAD, proximal LAD, angiography looks 2.5, the vessel is proximal, the LAD is long, the lady is not such a small lady, maybe this LAD is 3.0, or maybe it's 3.5, then you open the IVUS and you do that, or you have some dissection distally, you don't want to stent it, you want to ask a question, should I stent or not? So you have some kind of question that you want to address, and then you do IVUS to answer this question.
Okay, thank you. There's a question on the chat, Prof, about in an acute setting, intravascular imaging. So we've already discussed a little bit about OCT, but specifically looking for, if, for example, you see some little bit of haziness, but no luminal narrowing on the diagnostic shots, and then some people would use OCT to see evidence of plaque rupture or thrombus. How helpful is IVUS in this setting?
I think OCT is much better. OCT is much better in acute coronary syndrome. If you are an expert on OCT and you've already have stented and you do OCT and you see some haziness, you may find some residual thrombus distal, and that may make you take the decision to give some 2B3As for a short time.
Have we just lost the signal? No, you were just telling us, we lost you when you were telling us about if somebody is an expert with OCT.
Yeah, if someone is an expert with OCT, if you see some haziness, you can use these to decide if it's thrombus, if it's residual plaque, and if it's thrombus, you may decide to give some 2B3As, extra heparin, do a low pressure balloon inflation to break the thrombus. So I think OCT is definitely useful, but again, it has to be used in selective cases. But if you see the haziness, something may be better to use OCT. than IVUS. A vessel size is better to use IVUS.
Okay.
Stent malposition is better to use OCT. So I think you have to have specific questions, and you use the device to answer this specific question.
Okay, thank you. So we're coming up to the last few minutes now, just towards the end. Prof, I want to ask you, there's a lot of discussion recently and about these hybrid imaging catheters. So IVUS with OCT.
Yeah, I think these hybrid catheters are definitely interesting. They are, I don't have any experience. I have only experience of NIRS and IVUS. They are not cheap. They are quite expensive. So I think they are interesting, but I wonder if they're just a curiosity or something that you can really use.
Okay.
I was just visiting last week St. Francis Hospital in New York, and there is this operator, Richard Schlofmitz. He himself does between 10 to 15 PCI every day, and he uses OCT routinely in every case.
Every case?
Every case. He does angiogram and OCT. So it's amazing the way he does OCT, the way he can read OCT, interpret OCT. So I think when you see that, you become a little bit more open-minded. But you have to use it a lot. But believe me, you never. The message to me: don't be biased. You never finish learning, Arif.
That's something we definitely learned from you, Prof. And on the question of learning, it's really difficult. I mean, maybe this is myself, but it's really difficult to learn IVUS. That's my experience. I learned it, okay, for the first time when we were all working together. But do you have any tips for all of us young interventional fellows connected on how to really try to, apart from using it again and again and again, but if you use something without, it's not so easy because everything is black and white.
The best tip, Arif, is to take a month of vacation, go to Japan for 1 month. Go to Japan, to Sato, to our friends, 3 weeks, 2 weeks, maybe a month is too much. Okay. 2 weeks, stay there day and night, and you will take an advantage. You don't have to scrub, nothing, just put lead, stay behind them.
Okay. So 2-week crash course in Tokyo.
2-week crash course in Japan.
Perfect.
Or maybe maybe in Colombia with some good IVUS operator.
Great. So valuable lessons. I think we're just up to time. So finally, Rossella, thank you so much for presenting the article and presenting today on the last one. Prof, you enlightened the discussion for many, many years with all of us with the Journal Club, and especially today. So
okay. So Arif, let's try to do it maybe not every week, but maybe it would be a good idea to have every month.
Absolutely.
To have a common journal club. So would be our mission for 2022.
Perfect. And now that Sticky is there by your side on the left, we can see him.
Yes.
Sticky, mi raccomanda that you have to now together.
He will be the coordinator.
Exactly.
Okay. My honor also to organize for Japan.
Okay, fine. Okay. Prof, have a wonderful Christmas. Great holidays.
Take care. Very nice to be on with you. Ciao.
Ciao. Ciao tutti. Merry Christmas all and Happy New Year. See you in 2022.